Welcome to the Living Well and Redefining Aging series. I'm Cameron Siegel, and today we're going to talk about nutrition and food systems in elder care. At the table with me today, I have two really interesting people who have had completely different career paths, but actually have a lot of parallels in terms of what they believe in and the direction they feel our food system should go. I have Susie Polgreen, who's a registered dietitian with Beata Home Health here in town, and Tim Pratt, who's a food and beverage director at Living Well Group. I feel like we could talk about a lot of stuff today, and it could go on for definitely longer than half an hour. So let's just start with a little introduction. Susie, can you talk about yourself?
Yeah, so I have been a dietitian for about 5 years now. I just recently moved to the area from New York to work with Beata Home Health. I've been there for about 6 months.
Tim?
I have been involved in food for about 44 years now. I've split pretty much evenly between institutions and restaurant business, about 20 years in both, and I've recently come to the Living Well Group at about 3 months ago.
Cool. All right, so like I said, we could talk forever about nutrition, and I definitely don't want to make this just lecturing people about what to eat, what not to eat, the do's and don'ts. That's boring, and it's already been done. I'll just talk a little bit about how much nutrition has changed in the past 5 to 10 years. So it's pretty much a completely different field now to a decade ago, and that really starts with the food as medicine movement, right? So that's just understanding that in order to care for a body, you need to take into account what's going into the body, right? And just understanding that. And that idea is really intertwined with a new-ish field called psychobiotics, which is just believing and understanding that not all bacteria is bad, that there's good bacteria, and that there's a direct link between that bacteria and the gut flora and your behavior and your mental health. So given what we already know about good nutrition and how important it is, it definitely seems like we need to take into account the systems in place on a micro-macro level. So like in people's homes and in institutions. On that note, Susie, can you just lay out exactly what a dietitian does and what you would do if someone contacted you?
Absolutely. So dietitians are trained in what's called medical nutrition therapy, which aims to manage the conditions of a disease through diet. Now this can involve in-depth nutrition assessments to help identify the main nutritional concerns, followed by education and individualized nutrition plans.
Poor nutrition, that's a problem, right?
Oh yeah, so actually the elderly are especially susceptible to poor nutrition. 25% of older Americans suffer from poor nutrition. That's like a crazy statistic.
That's a ton, that's a lot. And
is.
especially Vermont, I think we're top 3 oldest states in the country, so that's a huge percent of our population.
Definitely.
I know that you know and have identified several barriers and issues, Susie, in your work. So can you just lay out one? Like let's start with one, and we'll have to unpack each one, and hopefully we can do it in 25 minutes.
Definitely.
I think we can. So just start with one and then we'll unpack
and
it.
the crazy thing is that these barriers that I've identified really have little to do with appetite, and they're all fixable. So number one would have to be difficulty cooking or grocery shopping due to either cognitive or physical limitations.
What are some of the things in place that help deal with that? Like, do they have food? They have food programs.
Yeah, there's so many resources that people that fall into this category can access, such as Meals on Wheels and grocery delivery programs through local grocery stores.
And congregate meals, I know that's a big thing at senior centers, and I know that nationally congregate meal numbers has declined, which is a problem, and a lot of that has to do with the quality of food. But Tim, you have direct experience with sort of a congregate meal program, food, but from an institutional side, as Susie has in the home, you're more the institution. So can you talk a little bit about some of the stuff you've done and specifically relating to what you did in Greensboro?
Yeah, so Greensboro Nursing Home was a 26-bed facility in Greensboro, Vermont. We actually started taking a hard look at, once we redesigned menus, we started taking a hard look at how residents were eating, what they were eating, and as far as the congregate meal site, we didn't necessarily have one there, but we started, we were baking all our own bread, we were making a lot of from scratch products. We were inviting the community to come into the nursing home to actually eat with our residents, and it turned into a little bit more of an event. We're actually able to bring in other people of between the ages of 65 to 80 that would come in and visit with their caregiver to visit a resident there. So we got to experience some of their difficulties that they found. So by doing that and kind of stepping into it, we actually were able to get a good hold on what was needed in the community before we executed anything.
So you, there's some actual numbers to what y'all generated, right? Like you actually made money at the nursing home?
Yeah, so our program started out really in baby steps. We took a look at making food available for our residents for snack time. It evolved into making food available not only for residents at snack time, but also family members wanted to buy small 8-ounce containers to bring home to an elderly person that was in shut-in. So then basically this blossomed into, after probably 2 or 3 years, actually blossomed into a wholesale retail bake shop and a catering business that we established around Caspian Lake. Generated at the height of it, generated between $25,000 and $30,000, which actually all benefited not only the residents but also the community, so that we were becoming self-sustainable as far as being in a remote area, that we were able to provide specialty items to residents and family members and the community that they probably wouldn't have seen before, otherwise.
Was there Meals on Wheels in that location before you did that?
No, there wasn't a Meals on Wheels program established at that time. We established a Meals on Wheels program probably 3 to 4 years after we started the other programs. A lot of that was really directly related to community outreach that we'd put into the community that came back to us saying that there was a greater need that wasn't being met. Within the area agency of aging in the Northeast Kingdom, we were able to, I think we were doing about 250 meals a week.
That's a lot.
That
In
is a
addition
lot,
to who was
yeah.
already living there?
In addition to not only the wholesale retail bake shop, but also the 26 residents, so yeah.
Wow.
What do you think about that, Susie?
That's a lot. Very impressive.
But you see the value in it, right?
Definitely.
So it's like coming
Oh.
from within the institution and it's reaching the community
Yes,
around it.
definitely.
So down in southern Vermont, they have these groups called CARES groups, which is basically just citizens in those towns who go around and they take elderly folk, older Vermonters, to doctor's appointments, to restaurants, basic grocery
that's
shopping.
great.
Yeah,
Yeah.
so like we already know that there's isolated people who need help, and there's definitely a stigma against getting Meals on Wheels. And that's not to trash Meals on Wheels, that's just, there's a stigma about getting old, so there's a stigma about senior centers, there's a stigma with getting home delivered meals.
Yeah, I want to say the majority of my clients get Meals on Wheels, and they like it. So
do?
yeah, it's something that I always recommend if I see that as a need.
But that's something that, Tim, that what you're, what you did down in Greensboro, bringing people into the nursing home to kind of like dull that stigma when it was time for them to move in somewhere. I think that's really cool. Do you have anything else that you want to add on that?
So actually working with dietitians, and dietitian that was working in Greensboro, we found it was more beneficial to bring people in or get as many people to come into the nursing home facility because we had access to trained people that would recognize deficiencies. So if a dietitian was there, she was noting something from a medical standpoint that was beyond my degree of expertise. Nurses would see them. So there was kind of it wasn't a formal evaluation, but if somebody we ended up having conversations either with the resident themselves or a family member that may have brought them in. So it was important that these people came to us also, not only just having the Meals on Wheels program, even though as important as the Meals on Wheels program is, because of the simple fact is they have a check-in. Somebody is at least there 3 times a week. They're kind of doing the same thing, but having them come into the facility itself was actually very beneficial. It wasn't a huge population, but it was community outreach that worked to some degree. So.
Well, I'm assuming in that area, those people would have been isolated if they weren't going there.
Being
anyway,
as
so
rural as Vermont is,
Right.
you're talking a whole nother situation in Northeast Kingdom. Is the distance between point A and point B is huge. So,
Right. Right.
Yeah.
So, like Susie, I think that if somebody calls in you or another dietitian to an older Vermonter's home, like do you play that role of sort of being that person
Oh, yeah.
visiting them? Like, how long are you there with them? Are you there for a while or?
I mean, it could be anywhere from an hour to 2 hours. You really have to wear a lot of hats. You walk in there, you scope out what are the needs, what are my main nutritional concerns here, and a lot of times it is isolation and loneliness. A lot of people don't like to eat alone, especially if they've lost a loved one that they're used to sharing meals with. So in that case, congregate meal settings are excellent.
Right. You think that if like a widowed person, like somebody's wife dies, somebody's husband dies, that's a big aspect of why
Oh yeah,
people
I've
don't
seen
cook?
that so frequently. That is a huge barrier to proper nutrition. You're used to sharing meals with somebody your whole life, and now you have this loneliness, and it affects your appetite, it affects your willingness to cook a meal. So yeah, these types of programs are excellent.
So your role is more than just being like, hey, this is what you should eat.
Yes. Yeah.
How would somebody get a hold of you? Like, would a social worker or a doctor have to recommend
So
you?
it's a referral-based system through Biata. If a clinician has a client that they think could benefit from nutrition, which most do, they will put a referral, and then I will go in and I will work with that client on whatever I see the nutritional goals to be. Yeah, and it's collaborative too. We both formulate goals together.
Well, that's healthcare. That's what healthcare
Yes,
should
definitely.
be in an ideal world, and it should have doctors, social workers, dietitians, and then the people preparing the food, like what Tim can talk about. So Living Well Group has started supplying congregate meals at the Heienberg Community Senior Center, which was having some issues with their food program. We keep throwing out congregate meals. I know what it is, you know what it is, you know what it is. Can you, Susie, talk about what a congregate meal is?
So it's like you're enjoying a meal in a social setting with other people, and it's very social. You have the opportunity, and the meals are very nutritious. I correct me if I'm wrong, but it's donation based.
Yeah.
Yeah, so it doesn't really, you just give what you can, and everyone just gets around and gets served these nutritious meals in this very social setting. So.
Right, so that kind of touches on the income limitations. You're not required to pay. They don't turn people away.
Yep.
Tim, do you have anything to add on the congregate meal thing?
Not on just the fact that actually it becomes an event, and again, it's the ability for people to get together that may not have an opportunity or a desire to get out of the house. This gives them a reason to do it, and then once they get it going, what we found that it was also very important that that there was other things going on, that we let them know that there was activities going on after if they wanted to stay, and if it was if they came in on a weekend and wanted, or we let them know that there was a football game on. So there was, again, it's just the outreach that's continuous and ongoing, and the congregate meals introduce people to perhaps a neighbor that they hadn't seen, that lives 100 yards down the road, but they couldn't get out of the house to see him, and it's they finally have seen him, and they light up to each other, and they have a conversation that goes on for forever about the last whatever 6 months or so. It's great to get these people out. It gives them an emotional release. It gives them somebody to talk to that they perhaps can trust. That they can tell their concerns about, whether it be financial bills or what their troubles may be. So congregate meals are huge. So it just gives them an outlet other than just a really good meal.
Right. And so my experience studying and working with senior centers, it isn't long, but it's very easy. It was very easy for me to quickly understand that, like, senior centers are volunteer run. For the most part, there are people who have established jobs, executive directors and stuff. But like those congregate meal programs, like, they rely on volunteers to feed, to dish out the food and stuff. So there's the benefit of the people eating the food, but also the people in their 50s, in their 60s, serving the meals and getting to. It's still working against that stigma of aging. So it's kind of just sort of what the role of this show is to introduce people to the conversation about aging, and that's what both of y'all do, and I love it. And
Well,
I think it's
like
really
what
cool.
Tim said, it's a social event. So I have clients that look forward to this, and they have it on their calendars of when the congregate meals are going to be, and they're very, very frequent. They're a couple times a week, depending on the area, and they really look forward to it. It's great, yeah.
And I know that there's an issue with even getting to the congregate meals. So there's people who really wish that they could, and there's some senior centers, depending on where you are, that based on funding, they're able to have like a van or a bus to come pick people up, but a lot of them don't, so that's where Meals on Wheels comes in to supplement that. So we talked about like the physical and emotional barriers, like physically not being able to go to the grocery store, go to restaurants, and then the emotions of being alone, losing a loved one that impact access to food. But there's like actually a biological basis to eating.
Yeah.
It seems obvious, but Susie, you know, she's got the master's degree. She's like, so like, teach us
defer to
about.
Susie.
So,
Yeah, we'll defer. Susie. Teach
regarding-
us about some of the biological factors that impact nutrition.
I mean, dental issues are huge. Either missing teeth, no teeth, ill-fitting dentures. They're very prevalent in this population, and they do affect, they do pose a barrier to proper nutrition. What I've seen is, especially with protein intake, as proteins can be, you know, sort of tough. So as a dietitian, what is the solution to this? You can incorporate softer foods such as Greek yogurt, cottage cheese, soft fishes like tuna, or puree the meat. But I think Tim can speak on how, you know, he worked in a facility with, you know, where you were pureeing everything.
Yeah, so basically what we did as far as protein levels, and protein is always probably one of the highest on the list as far as intakes, and then the lack of intake, skin integrity, skin tears, decubitus ulcers. I mean, the list goes on that protein actually has a high level of involvement of curing. So we actually, from a standpoint, my background in cooking, some of it's French continental cuisine, so I took another look at how we were able to get protein into residents that were protein risk. We actually, I'm not proud to say it, but we actually hid a little bit of tofu in
I love that.
the oatmeal in the morning, and we pureed that up. We put it in the oatmeal for everybody. So everybody was consuming a little extra tofu. We put a little bran in there for obvious reasons. And then actually we took a look at stepping a little back a little bit farther. And instead of making people a regular diet with minimal amounts of changes to it, I took a look at how can we make everybody eat a pureed diet. So when I first came out with this, people looked at me like I had 3 heads. But so we took a look at French continental cuisine, which is the backgrounds of mousses and terrines and a number of items that go into the French cuisine that is theoretically pureed before you actually cook it and or consume it. So I made it a point when I redesigned the menus in Greensboro, we made it a point to actually put 2 pureed diets into the rotation of the menu twice a week. So we were doing French continental cuisine basically for everybody. So we were doing seafood terrines, we were doing mousses and pâtés and all these different French dishes that I was selling in my restaurant when I had it that turned into being extremely popular. We were doing hollandaise sauces. We were doing cream sauces with herbs and lemon juice in order to stimulate the palate for the elderly. So, and then we went even further than that. So when we took pureed diets for people on a regular diet, we would puree the food. We actually took proteins, chicken, beef, pork, in a raw state, and then actually broke them down and pureed them with heavy cream, which is another high fat intake level of which a lot of elderly need. And also we pureed with eggs, and then we would actually steam them or poach them. And then we would slice them.
That sounds really good.
And present them with gravies and or different sauces, and then add extra sauces on the side so that the meal could be prepared actually tableside for people who are eating the pureed diet.
Well, that's so like when you say pureed, and I'm assuming, I'm not going to speak for the audience, but like I think of cafeteria slop when I just say the word pureed, but it doesn't have to be that way, right? I mean, and like you were instructor where? At the Vermont Culinary Institute?
I was brief with the New England Culinary Institute. I was one of the original folks in the kitchen when they first established themselves. But that's actually, beyond that, we really started playing with the pureed diets in Greensboro, and then took a hiatus because I actually got out of the nursing home industry. But when I was at Wake Robin as the executive chef there, we brought back the pureed program and established the pureed program there also. And it was met with some pushback, but then once we got past that point, quite a bit of success.
Good.
We actually in Greensboro found that we had about 30. We did a study and we had about 30% increased consumption that for the people who were on a pureed diet.
30%. That's
30% consumption
excellent.
increase, and then we also found out that a lot of that was also because that the person that was at the assisted table and the person that was helping them eat, that was assisting them, was more engaged with the food because the food was more than just 3 plops on a plate. It was actually presented like we would have in a classical cuisine restaurant, high-end restaurant. It was sauced, it was presented, and we found that people were actually more engaged, so therefore it transpired into a higher consumption rate.
Tim, you've done the impossible. You've made puree diets appetizing.
And she just said 25% of older people.
Yeah,
are poor
this is a
nutrition,
huge
so,
issue, and it can be done.
Right.
This is great. Yeah,
it can
this
be done.
is-
Yes.
I think a really interesting point that you touched on, and we don't actually have that much time, 'cause I really would like to talk more about that, is like
Yeah.
the presentation of the food and like, chefs making food that isn't just throwing everything into a blender, dumping it into a cup and giving it to someone with a straw. It's like you really can, plate it, right? Like that's a restaurant thing,
Yeah, it
right?
was basically the same plating concept that goes on in restaurants. It was done with maybe not the finesse that you would speak to, but it was presented in a manner of which with respect. That's really what it came down to. So we concentrated on the people, and in Greensboro we had a higher rate of pureed diets, so it only made sense. Sometimes half of our population at one point when it might have been on a pureed diet, which if we weren't paying attention to that, in my opinion, is doing a disservice to those folks.
Absolutely.
Because people age, let's face it, people get into a situation where they're not as capable as they were before to consume the food, but it doesn't mean that they're maybe still not hungry.
Right.
And certainly don't want to be treated, their food to be treated any differently, so.
And there's, so when I think of pureed, I think of slop. I don't anymore after hearing that. But like, it's not bland, right? Like it can't be bland. And there's some truth to bland food being really bad
Yeah.
for aging individuals. Susie, can you just touch on that?
Another huge deterrent I've seen in proper nutrition is that as we age, our taste buds decrease in number. And our sense perception decreases as well, which can make food seem less appealing. So bland food is kind of making that even worse. So the best way to combat this is to get creative with spices. Use things like oregano, garlic, parsley, dill to enhance the flavor. Also, foods are most flavorful when either hot or cold, rather than at room temperature.
I don't want to eat room temperature food anymore.
Ew.
So we have just a little bit of time. Let's talk about farm to institution. I think it's a really cool thing. And before we really talk about it, Susie, you have some experience in the pushback to that movement,
Yes,
right?
I
Can you
do.
just quickly talk about that? And then we'll go to Tim and have him
Yeah,
talk
the
about
success
what we're doing
story.
in Eaton Woods and the success on it. So Susie, talk about
Yeah.
the pushback.
So even living in New York 4 years ago, I did try to implement a sort of farm to institution type program, and it really wasn't taken very seriously. I didn't really get far with it. I don't know if that's financial reasons or just a lack of knowledge at how beneficial these things can be.
So what did you real quick, what did you want to do? What was you applied for a grant to do
I applied
what?
for a grant to have a garden that, in turn, the fruits and vegetables that were made in the garden would be used in the meals for cooking for the patients. And it did.
It's not crazy.
Yeah,
It's not crazy. It's not crazy.
Yeah.
And Tim, you have a successful grant story. Can you talk about your life grant?
So I started this goes way back to Greensboro again. We actually had a garden. I was doing this before we had a name to it, I guess. I called it Common Sense. But so we had a backyard garden so that residents were actually participating in the planting, the growing, the harvesting, the picking, the preparing of some of the food. So they'd sit around and talk about the old days and how they used to do this. So it made sense to me because of farm to institution. One of the greatest things we have to combat against is trying to find farmers and chefs that have enough time to get together and plan all this out. So I went one step farther and decided that maybe it'd be a good idea if I started a nonprofit called Life, and basically it's all about bringing the garden to the facility. So we started this year at Heaton Woods in Montpelier, where the grant was for putting up a greenhouse, preparing garden soil, and then further planting, harvesting, so that we're actually putting the ability to have the fresh vegetables in the backyard of the kitchen, so that the chefs are harvesting right there in their backyard, cooking that meal. The plan is that hopefully that the garden will be producing fresh produce for all of Living Well's facilities, and there's a garden in Ethan Allen also that will hopefully prepared. We'll be growing herbs, so they'll be giving us herbs. We'll be giving them fresh produce. So hopefully with a good growing season in Vermont, we'll be successful.
Yeah, it's already snowing in November, so
Yeah.
that's rough. All right, we are very close out of time. Do you have anything else?
I really like this farm to institution movement. I mean, quality food is just better nourishment for our bodies. And I always tell people, well, you don't spend on food now, you're going to spend on your doctor later. So, which circles back to the whole food is medicine.
Right.
Food is medicine.
Right. And it's common sense.
Yes,
Like, it really
like
is.
Tim said.
It's not rocket science. It's common
Yeah.
sense, and we talked a bit, in the last episode about the engaging with the garden and the value on that. So I love it, and again, we could talk about that for another episode. So I want to thank y'all too for coming on here and
Thank
talking.
you so
for
much.
a short time. Living Well Group offers consulting services to assisted living and residential care facilities, and Beata is available to do a ton of stuff: hospice work, dietary.
Yep, physical therapy, occupational therapy, speech and language therapy, psychosocial services, and of course, nutrition.
All right.
Yeah.
Thank you. I appreciate it.
Thank you, Cameron.
Thank you.